Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. In this video, we're going to start talking about respiratory disorders. More specifically, in this video, we're going to talk about pneumonia, COPD, asthma, and carbon dioxide toxicity. So let's start. Pneumonia. What is pneumonia? Pneumonia is actually inflammation of the lungs due to either a viral or bacterial infections. Some signs and symptoms will note with this patient will be crackles, wheezing. For older adults will note confusion prior to even noticing that they are having pneumonia. And the patient could also have fever, SOB, which is shortness of breath, chest pain, dyspnea, as well as coughing. Some labs that will watch out for this patient. We always remember to collect a sputum sample prior to administering our first round of ABTs, because most of the time the doctor will order a broad spectrum antibiotic before we get the sputum culture, just to start working on the infection so the patient does not get septic. And we only administer the ABTs after we collect the sputum, right? Will note an elevation with a WBC, which are white blood cells, as well as a decrease in our PaO2 levels, which is our oxygen levels, which is normally between 80 to 100. Some nursing care that we need to know about this patient will position this patient in a high-fowlers position. Why? To open that airway, open the lungs for easy breathing. We will administer oxygen as prescribed. Remember, they are having this inflammation, so breathing is an issue. We'll encourage the patient to practice coughing and deep breathing and use of an incentive spirometer. And they will need to increase their fluid intake to thin down that mucus for easy coughing it out, to bring it out, to prevent it colluding or blocking the airways. Some diagnosis that we use to diagnose somebody with pneumonia, we normally do a chest x-ray, and once a consolidation is noted, then this patient has pneumonia. Some medications that they give this patient include the antibiotics, of course, as we talk about. They'll start with broad spectrum, then they go to, they narrow it. We'll give them bronchodilators, the albuterol, open that airway, help them to breathe. We'll give them anti-inflammatory. Remember, it's an inflammation of the lungs, like glucosteroids. For patient education, we will educate the patient on how to administer this medication. Remember, antibiotics through the ABT therapy. You stop antibiotics in between before completion, you are risking resistance to this antibiotic. We'll also do preventive measures for pneumonia, and we can also give this patient pneumonia influenza vaccine. We could offer it to them, especially the elderly adults. Next up, let's talk about asthma. What is asthma? Asthma is a chronic inflammation disorder of the airway, is intermittent, and is reversible. So some signs and symptoms of patients with asthma, the classic sign that you'll see in most tests will be wheezing. So the patient will wheeze. They'll have this prolonged cough because they're trying to push out air out of their lungs. They'll have exhalation. They will have low O2 saturation. They'll have a buried chest, and they will be using accessory muscle to compensate for insufficient oxygen perfusion. Diagnostic tests that we use for this patient will do a pulmonary function test, either FVC and FEV1. Medications that we normally give these patients include bronchodilators. We have the SABA and the LABA, which are short-acting bronchodilators, and long-acting. We'll give them the anticholinergic meds, which dry you up. You can't pee, can't poop, can't swallow, your dry mouth, dry eyes. It dries you up. It dries everything up. And also we'll give the patient anti-inflammatory medication because it's an inflammatory disorder. One thing to note about asthma is something called status asthmaticus. Status asthmaticus is an airway obstruction that is unresponsive to typical treatment. This is an emergency, and we always have to provide this patient with oxygen, bronchodilators, and be ready to intubate this patient because they are not responding to the typical asthma treatment. As well, we'll also have epinephrine ready to administer for this patient, and we always place this patient in a high-fowlers position. Remember, patient with airway compromise, we need them sitting up. Sit them up helps them to open that lungs, open that airway to help them with ease of breathing. Next, let's talk about COPD. What's COPD? COPD is chronic obstructive pulmonary disease or disorder, some people call it, and it's a combination of either two different conditions. It could be emphysema and chronic bronchitis. What is emphysema? Emphysema is when your lung or the alveoli in the lung loses elasticity and hyperinflation of the lung tissue. So they're inflamed, right? The lung goes there. So it's like a balloon. You keep damaging that balloon, blowing air. The elasticity wears out. And chronic bronchitis. What is bronchitis? It's itis, inflammation of the what? Bronchi. So it is an irreversible condition, and it's mostly due to smoking, which is our primary risk factor. Signs and symptoms of this include clubbing, which is a classic sign that you'll see in most tests, and barrel chest as well. This patient will have dyspnea upon exertion. You'll hear crackles as well as wheezing. They'll be using accessory muscles for that compensation. They'll have hyperresonance when performing percussion due to the trapped air in there, right? Hyperresonance due to the air in there. There's something in there. They'll have low levels of O2, and they will have rapid and shallow respirations. With this COPD patients, they normally run low, so don't give them too much of oxygen. They're normally on a 2-liter level oxygen. If you give them too much, you will end up killing them. Don't do that. So with COPD patients, as I said, they normally have a low O2 level, and some labs that you need to note, or you'll note with this patient, they'll have a high hematocrit level due to low O2s, right? They'll have PO2 levels below 80 because our norm is between 80 to 45. Our PCO2 levels will be greater than 45. Remember, norm is between 35 to 45. They will end up in respiratory acidosis with a pH level below 7.35 because they're retaining more carbon dioxide in their system. Some nursing care that you need to know with this patient: high-fowlers position. Always have them in high-fowlers position to open that airway, help them with breathing. We also encourage the patient cough and deep breathing, use of an incentive spirometer. We ensure proper nutrition because with this patient, I normally tell people you can't breathe, you can't eat. So they are having difficulty eating because they're not breathing well and they are tired. So what do? We offer these patients small meals packed or high in calories and protein as well. And we teach the patient special breathing techniques, which are abdominal breathing or press lip breathing to decrease that O2 saturation. Some medications that we normally administer to this patient are bronchodilators, beta 2s, right? Anti-inflammatory medication because of the inflammation of the bronchi, mucolytic agents because of the thick mucus. You need to mobilize it. We give it to them to thin them out. One of the complications that we need to know about patients with COPD is called pulmonary, which is the patient with severe COPD can end up with right-sided heart failure, which is called pulmonary. And some signs and symptoms of this is dependent edema, JVD, which is distended jugular veins, and enlarged liver. So let's talk about cor pulmonale. So cor pulmonale is the right-sided heart failure caused by pulmonary disease. It is a COPD complication. So signs and symptoms will include hypoxia, which is a low O2 level in the body tissues, and hypoxemia, which is low O2 levels in blood, right? We're going to have extreme dyspnea, difficulty breathing. They're going to have cyanotic lips. They're going to have the JVD, dependent edema, hepatomegaly, which is the enlarged liver, and pulmonary hypertension. They are retaining this fluid, right? So medication include diuretics to flush the fluids out, digoxin to help the heart dig deeper and pump this fluids around the body. We're going to monitor respiratory status, cardiac status, and assess for indication of right-sided heart failure. Of course, we're going to give this patient oxygen and medication as ordered. We're going to maintain a fluid balance, right? Most likely they'll be on fluid restriction because their heart is not functioning properly, because if this fluid is not moving well, they're going to end up with fluid retention. We ensure adequate rest periods because remember the heart is not functioning very well. We don't want to have it overwork the heart. So give the patient some rest period or encourage them or teach them how to have these rest periods to give the heart an effective way of working. And low sodium diet. Why? Because we say wherever salt goes, water follows. So these people, we don't want them retaining this fluid. Their heart is not functioning. It's not going to be able to pump this fluid around and out of the body. And mechanical ventilation may be required for this patient if they go into severe respiratory distress. So lastly, on this video, we're going to talk about carbon dioxide toxicity. What is carbon dioxide toxicity? This is TRPS secondary to increased CO2 retention, so carbon dioxide retention. And some causes include carbon dioxide retention, right? If you're retaining carbon dioxide in your body, and excessive O2 delivery. And this is normally with patients on ventilators, ventilated patients. Signs and symptoms of this include tachycardia with dysrhythmias, increased blood pressure, tachypnea, and altered LOC, which is level of consciousness. So what are our interventions? What should we do when a patient is going through a carbon dioxide toxicity? Well, monitor our pulse oximetry and more importantly, our ABGs, right? We avoid excessive O2 concentration. We'll check that patient on ventilator if they are, we are hyperventilating them. We need to watch on that. We provide pulmonary hygiene, our oral hygiene. We'll provide ventilator support with CPAP, BiPAP, or mechanical ventilators. We always remember that CO2, carbon dioxide, is what triggers or makes the brain send signals to your respiratory system to breathe. So we need to maintain a hemostasis, a level for you to be able to have that signal to be able to breathe. Otherwise, you'll stop breathing. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.